It's nice to be here. Thanks everyone for coming. Let's just jump right into it and start with our learning objectives. So we're going to start with comparing extended release buprenorphine to other opioid agonist treatments, including the benefits, side effects, and additional considerations. We'll then go into discussing induction strategies for extended release buprenorphine. And then finally, we'll talk about strategies to prevent and manage breakthrough withdrawal for people receiving extended release buprenorphine. I think also just to make it quicker, I might be calling extended release bup, just to get through those three long words faster. So buprenorphine is a synthetic partial mu-opioid receptor agonist. It has a very high affinity for the mu-opioid receptor, which means that it can displace and block full opioid agonists, such as fentanyl and methadone, from binding to the receptor. Due to its partial agonist properties, buprenorphine does not activate opioid receptors to the same degree as a full opioid agonist. And so if a full opioid agonist is present on the receptor, its rapid displacement by buprenorphine can result in precipitated withdrawal. Buprenorphine also has a lower intrinsic activity at the mu-opioid receptor compared to a full agonist, and that results in a ceiling effect on respiratory depression, which means that a higher dose of buprenorphine does not necessarily increase respiratory depression like it does with a full agonist. And so for that reason, buprenorphine has a superior safety profile and lower risk of toxicity compared to a full agonist. So there are two formulations of buprenorphine that are commonly used for opioid agonist treatment in BC. We have our sublingual buprenorphine / naloxone, and then we have extended release buprenorphine. There are numerous formulations of extended release buprenorphine that are available around the world. In BC and in Canada, Sublocade is what is available and what we will be discussing today. And when I refer to extended release buprenorphine, that's what I'm talking about in this context. Next slide. Great. So extended release bup is a long-acting formulation of buprenorphine that is, according to Health Canada, indicated for the management of moderate to severe OUD, opioid use disorder, adults 18 years and older who have been previously stabilized on 8 to 24 milligrams of sublingual buprenorphine. Individuals stabilized on up to 32 milligrams of sublingual buprenorphine or fewer than 7 days of sublingual buprenorphine may be initiated on extended release buprenorphine. It's administered as a monthly subcutaneous injection via prefilled syringe. That's available in two dose strengths. We have a 100 milligram dose and a 300 milligram dose. It can be administered by a physician, nurse practitioner, RN, RPN, or RPN CP OUD. LPNs, RNs, and RPNs may administer extended release buprenorphine with a client-specific order from a physician, NP, or CP OUD, RN, or RPN. So since extended release buprenorphine is administered once a month, there are reduced clinic or pharmacy visits compared to other forms of OAT. Extended release buprenorphine is fully covered as a regular benefit for those enrolled in BC pharmacare plans B, C, G, and Z. It's also covered under non-insured health benefit for First Nations people who live in BC but may be residents of other provinces. So given the longer duration of action compared to other oral options, we need to consider the client's readiness and interest in extended release buprenorphine and any previous experience on buprenorphine / naloxone that they may have had sublingually before. So it takes 2 months to achieve a maintenance dose in most cases. There's no take-home doses as it is administered monthly by a healthcare provider. And a rotation to other opioid agonist treatments is challenging, especially full agonists. And so, based on clinical experience, if a change in medication is needed, one can consider trialing a switch to sublingual buprenorphine first, stabilizing on sublingual for at least 4 to 8 weeks prior to switching to another opioid agonist treatment. Next slide. So here's a comparative overview of 4 forms of OAT. Extended release buprenorphine, as we said, is a partial agonist. It's a monthly dosing. It takes 2 months to reach a maintenance dose. No take-home doses. And yeah, as we said, it requires fewer clinic visits, which may be preferable for some clients. in certain situations. Buprenorphine/naloxone is our sublingual medication, same medication, so it's a partial agonist taken once a day. Takes about 1 to 2 days to reach a maintenance dose via a traditional induction, and 5 up to 10 days to reach a maintenance dose with a low dose induction. And generally, clients are eligible for immediate take-home doses. Methadone and slow-release oral morphine are both full agonists. They're both taken once a day. Methadone takes often weeks to reach a maintenance dose, whereas this can be done a little bit quicker, often with Cadian, maybe in 1 to 2 weeks. And then in certain circumstances, in monitored circumstances, often quicker. For both, take-home dosing is possible after a minimum of 4 weeks of stable medication adherence, in addition to clinical and psychosocial stability. Next slide. Thank you. So both the buprenorphine-based medications have a milder side effect profile, while methadone and SROM have more frequent, severe, and dose-dependent side effects. So with extended-release buprenorphine, injection site pain and pruritus can occur. So we often advise clients to seek follow-up care if they have a rash, itchiness, or pain that is persisting or worsening post-injection. We can often use ice packs, acetaminophen, and a lidocaine injection or lidocaine jelly can be administered for pain management prior to the injection. Just to note that RNs and RPNs CPOUD may only administer lidocaine by injection before an extended injection if they're acting on a client-specific order from a prescribing MD or NP. So buprenorphine-based medications have fewer drug interactions. Methadone has the highest potential for adverse interactions, whereas slow-release oral morphine also has fewer drug interactions than methadone. Both buprenorphine-based medications have a lower risk of drug poisoning. We talked about the ceiling effect with respect to respiratory depression for buprenorphine. Methadone and SROM have a high risk of drug poisoning compared to buprenorphine. Now, methadone is associated with QT prolongation. Buprenorphine has a much lower risk of QT prolongation, and slow-release oral morphine is not associated with QT prolongation. So that means that if you are prescribing methadone, more intensive monitoring is needed for individuals with pre-existing risk of QT prolongation, such as another QT prolongation medication that they're taking concurrently, or a family history of sudden cardiac death. Buprenorphine naloxone has a risk of precipitated withdrawal, particularly during traditional inductions, and this risk is decreased with low-dose inductions or microinductions. I don't think I've actually defined this yet, but precipitated withdrawal is sudden worsening of withdrawal symptoms when a partial agonist, such as buprenorphine, is given to a person who has a full opioid agonist, such as fentanyl, on their opioid receptors. Methadone and SROM do not have a risk of precipitated withdrawal. And if someone has been fully stabilized on buprenorphine naloxone first, then there is no risk of precipitated withdrawal with extended release buprenorphine. That being said, there is still a risk of precipitated withdrawal with a rapid induction or a cold start with extended release buprenorphine. There's substantial evidence for the use of buprenorphine, naloxone, and methadone compared to slow-release oral morphine. In the absence of patient preference or other client-specific factors that would favor other medications, buprenorphine naloxone may be considered as the favorable OAT option due to its superior safety profile. Next slide. Thank you. So the US FDA, the Food and Drug Administration, recently announced label changes for extended-release buprenorphine. They have said that extended-release buprenorphine can be initiated after a single dose of buprenorphine sublingually, followed by a 1-hour observation to confirm tolerability. They've also approved alternative injection sites. Keep in mind, these are still subcutaneous injections, but now it can be the abdomen, thigh, buttock, or back of the upper arm. And the second dose of extended-release buprenorphine can be administered as early as 1 week after the first injection. So these were changes by the FDA. Health Canada is reviewing the product monograph and is expected to make a decision in early 2026. So in BC, some providers may be offering alternative injection sites now. However, the second dose cannot be administered in community settings earlier, as BC PharmaCare only covers a new dispense at least every 25 days. So for a typical induction, patients should be stabilized on 8 to 24 milligrams for a minimum of 7 days before transitioning to extended release buprenorphine. That's as per the product monograph. Um, generally we prescribe an initial dose of 300 milligrams, and at least 26 days after the initial dose, we administer a second dose. Depending on patient circumstances, the subsequent dosing of extended release buprenorphine may vary, but typically given every month. Next slide. So here's what it looks like. We have dose 1, 300 milligrams, at least 26 days after, we administer dose 2. For clients who have been stabilized long-term on less than 18 milligrams of sublingual buprenorphine, we can prescribe a 100 milligram dose. For clients who've been stabilized on more than 18 or more of sublingual, we prescribe a 300 milligram dose. That was a change that was made to the product monograph probably a couple of years ago, based on some additional modeling that they did with the plasma concentrations. So sometimes people aren't aware of that. Next slide. The third and following doses of extended release bup are considered the maintenance doses. So the maintenance dose for extended release bup depends on someone's opioid tolerance. We'd want to consider whether the individual has had a history of significant fentanyl use, response to treatment in the past, presence of withdrawal symptoms or cravings between doses, reports of sedation or constipation, and then finally, whatever their previous dose regimen was that worked for them. So to determine the appropriateness or the appropriate maintenance dose for each individual, we should consider the following to see if any of these indications are present. And so we have high sublingual buprenorphine stabilization dose, frequent use of supplemental sublingual buprenorphine, PRN, intravenous opioid use prior to sublingual buprenorphine induction, significant withdrawal or cravings after the second extended release bup injection, and clinical instability on a 100 milligram maintenance dose. And clinical instability may include clients missing appointments, experiencing withdrawal symptoms, returning to non-prescribed opioid use. If any of these factors are present, we should consider prescribing a 300 milligram dose. If none of these factors are present, generally speaking, we can prescribe a 100 milligram dose. And then we want to continue to assess for clinical response. So is that client having a satisfactory response to the 100 milligram maintenance dose? If yes, we can continue it. If no, consider increasing the maintenance dose to 300. So hopefully we have time at the end to talk about this in the question period. But a more rapid transition to extended release buprenorphine and that is like less than 7 days may be appropriate for some patients. There's really no magic to the 7-day number. That was the number that was chosen in the initial trials. And I think many of us have been not always necessarily waiting until day 7 to transition, depending on the client specific factors. So yeah, people may be transitioned to extended release buprenorphine from anywhere between the first 4 milligram sublingual dose of buprenorphine and dose of sublingual buprenorphine, depending on the client's preferences, context, other factors. This is off-label prescribing as per Health Canada's product monograph. And so prescribers can call the BCCSU's 24/7 addiction medicine clinician support line for support during rapid inductions if needed. Okay, so breakthrough withdrawal and cravings can occur while someone's taking extended release buprenorphine, particularly at the start of treatment. Clients may experience breakthrough withdrawal symptoms or cravings during initiation and titration, several days before their next injection, or consistently, irrespective of their treatment status. If a client's experiencing breakthrough withdrawal, it's important to explore potential physical and psychological contributors to breakthrough withdrawal. Physical contributors to breakthrough withdrawal include severity of their opioid dependence, medication interactions, unknowingly using benzodiazepine adulterated opioids. Psychological contributors can include anticipatory anxiety of going into withdrawal, mental health conditions that could exacerbate subjective withdrawal symptoms, such as mood or anxiety disorders, and then conditioned environmental cues. So when we're speaking to someone about breakthrough withdrawal, it's important to approach the conversation with a respectful and non-judgmental tone. So questions that we can ask are you experiencing any withdrawal symptoms or persistent cravings? How often and when do you experience withdrawal symptoms? And can you describe how severe or intense these are and what can generally help with that? So in terms of managing breakthrough withdrawal, one option is to increase the maintenance dose to 300. I think if someone's experiencing breakthrough withdrawal and they are still in the 100 milligram dose, that would probably be my first step. If that's not effective, breakthrough withdrawal can also generally be managed by prescribing additional sublingual buprenorphine / naloxone, daily PRN, so up to 8 milligrams a day as needed. And so, collaboratively determining dose adjustments with the person receiving care based on their symptoms and their experience. If an individual requires more than 8 milligrams of sublingual buprenorphine per day, you can also consider calling BCCSU 24/7 addiction medicine clinician support line. A need for ongoing PRN sublingual buprenorphine doses varies. Fewer doses may be needed after the second dose of extended release bup. Some individuals may continue to need sublingual buprenorphine PRN for an extended period, and evaluate ongoing sublingual buprenorphine PRN prescription on a case-by-case basis, depending on each individual's needs. And then finally, prescribing sublingual buprenorphine PRN as take-home doses for those who meet take-home dosing criteria. And so we just want to make sure that we're discussing medication management and safe storage with our clients. So in summary, extended release buprenorphine is a long-acting formulation of buprenorphine. It's administered as a monthly subcutaneous injection. Monthly extended release buprenorphine injections may be preferred for individuals stabilized on sublingual buprenorphine due to reduced medication burden. A typical induction onto extended release bup involves a patient being stabilized on 8 to 24 milligrams for a minimum of 7 days before transitioning, as per the product monograph. But as we talked about, many clinicians are transitioning folks to Sublocade before then. Breakthrough withdrawal while on extended release buprenorphine can occur during initiation and titration, several days before the next injection, or consistently during treatment. And breakthrough withdrawal can be addressed by increasing the maintenance dose to 300 milligrams and or by prescribing supplemental sublingual buprenorphine. And these are some resources from the presentation. And references.